Everyone for joining us this afternoon for this month's Teach Educational Rounds. Here with us today, we have Dr. Tarek Rajji, who will be joining us momentarily, as well as Dr. Peter Selby, who will be presenting on dementia and smoking, prevention and management of tobacco use disorder. So before I hand it off to them, I'm just going to go through a few housekeeping slides. So if you're interested in receiving a letter of completion for this Teach Educational Rounds, please make sure you have registered for the webinar and completed the pre-learning assessment. Please make sure you have also signed into the webinar using your full first name and last name so we can track your participation. And please make sure to complete the evaluation and post-learning assessment that will be emailed to you by the end of tomorrow. And please note that a copy of today's presentation slides as well as the recording will be sent to you this afternoon as well. So here's a little bit more information on our presenters today. So Dr. Tarek Rajji is a professor of psychiatry and the director of the Geriatric Psychiatry Division, as well as the executive director of Toronto Dementia Research Alliance. He is a part of the Timurti Faculty of Medicine at the University of Toronto and is also a Canada Research Chair in Neurostimulation for Cognitive Disorders. And last but not least, the Chief of Adult Neurodevelopment and Geriatric Psychiatry Division here at CAMH. So I'll give you a moment to read through his disclosures.
So are you having any difficulty with him being made into a panelist, is it?
Yes. Okay. So, yeah, usually we're able to just, if someone joins as an attendee, we can just make them a host, but for some reason it's, not letting us this time around. So we're trying to troubleshoot with that.
Yeah, should he try in my, okay, well, we'll see what we can do. We'll have to figure out a way. We may have to have him, you can unmute an attendee, can you not with this or not?
So usually you can, but for some reason it won't let me specifically unmute Tarek. I'm not sure why that is.
Okay.
Yeah. So in the meantime, I'll introduce you to everyone. Okay. So Dr. Peter Selby is our very own. He's a senior medical consultant and a clinician scientist at CAMH. He's the interim vice chair of research, Giblin professor, and director of addictions and mental health division for the Department of Family and Community Medicine, and a full professor in the departments of psychiatry and the Della Lana School of Public Health at the University of Toronto. His research focuses on innovative methods to understand and treat addictive behaviors and their comorbidities. He also uses technology to combine clinical medicine and public health methods to scale up and test health interventions. His cohort of more than 300,000 treated smokers in Ontario is an example of this work. So I'll also give you a moment to read through his disclosures. So please note that the content of Teach Educational Rounds is centered on evidence-based guidelines from the following sources. Nonetheless, these materials, as well as the verbal presentation and any discussion, represent only general principles, and they do not remove the need for clinical assessments or treatment plans by healthcare professionals. So please feel welcome to use the chat feature throughout the webinar to post any comments or answer any prompts. To do this, you can click on the speech bubble icon in the control panel. And please ensure you select everyone so that all panelists, hosts, and attendees can read and respond to your comments. All right, so with that, I will leave it to our presenters to take it away. I'm just going to see if we were able to figure out the technical difficulties with Dr. Rajji.
So if Dr. Rajji hasn't come, so I'll just start off with one of the reasons why we are starting these series is that smoking plus, and we're beginning to see these parallel pandemics emerge, and in preparation for an aging population and the problems of dementia and the role in which we've been beginning to see older adults coming into our clinic to quit smoking. And then, many, some of you on this call, I can't see all the participants listed, but over the years, we've seen a lot of people who've told us that they've had people with dementia coming in to quit, or there are people in nursing homes. And we've done consults with people. A big shout out to Marilyn Campbell. I'm not sure if she's here been able to join today, but Marilyn White Campbell is here. I see that she's there. Has really been helpful in opening my eyes to the older adult population and their needs, especially some of the complicated consults we've done. And so we've also had to deal with, for example, some of our nursing homes or places where people with mental illness and seniors with mental illness are staying, and some really critical issues around dementia and how to handle that. So we thought, what about having Dr. Rajji actually come and talk to us, who is an expert in dementia and adults and aging adults, and as a geriatric psychiatrist, and also, leading the Toronto Dementia Research Alliance to tell, what are some of the things that they're seeing, what are some of the things that we need to be mindful of as we age, as well as patients age. So how do we do this? So that was the whole reason for setting this up, and why we wanted to have this. And I'm pretty heartened to see so many people have joined. What I'm going to suggest, and I don't know if Natalie can hear me, is maybe we'll just flip. I was going to have him open up the discussion around dementia, but if we can't, maybe we'll just go to my section of the slides, and we'll do my presentation while you're trying to help him get involved. So
Sounds great.
Yeah.
Did you want to share the slides, or would you like me to share them?
Could you don't mind sharing, and then just make me a presenter, please?
For sure.
Yeah. So yeah, I see he's there, but he doesn't have his mic connected. I think that's the issue. His mic is not connected.
Yeah, he said it was. So yeah.
Yeah, I don't see his mic or his audio connection. So anyway, so if you just go to my section, which is section 2,
Yes.
that would be helpful. So while we're waiting, I hope everyone is doing the best they can during this pandemic, and thank you for taking time out of your busy schedule to be with us this afternoon. And we're really apologize for this technical difficulty. I think we're running into some problems with this, and I know Dr. Rajji was trying from a quarter to 12 trying to get on. So what I'll do is just go to my slide. Or have you made me a presenter?
So the updates with WebEx don't allow for someone to kind of do.
Okay.
Yeah. So you can just let me know when you want me to change the slides, and I can do
if
that.
you go down to my section, which is the second. Yeah. So I'll just speak to the issue around modifications required to assist people with dementia, and if we can. Go to the next slide, please. So first thing is, as we have to look at it, is where is this person situated? Is this person, and this is how we approach it, are they coming in from an inpatient unit, either in the hospital or in a nursing home or somewhere where that is an issue about them smoking, or are they transitioning from the home, moving into a assisted living or a place where they may have less autonomy and in smoking and have again, which heightens the risk to them? Or are they coming to us as an ambulatory person? They have some cognitive impairments, but not, but pretty much they're able to consent, they're able to understand and appreciate what we're trying to do, and are expressing a desire to quit and do have at least some capacity to plan ahead and to work towards quitting smoking. So that's those are the things that we're really thinking about as to where are we trying to do this kind of work with this person, where are they situated. and what is the external and internal motivators to quit? And sometimes they are not necessarily aligned, because the person may not want to stop, but is facing a potential being discharged or becoming homeless, because if they continue to smoke, that they're violating a policy, and there's not safe for them to smoke where they are. So that's why those are some considerations that we have to pay attention to. The other one is, even if they are, who is the regular, support team around them? Do they have a physician, nurse practitioner, other healthcare provider? Or even some places where they are, for example, we see a lot of our seniors, at least at CAMH, who are quite well connected to their dental care and have dental supports. And so we do see that group as well. So this having regular contact is considered critical for older adults in their quit journey. So we often try to figure out who else is part of their circle of care whenever possible. And it goes beyond, obviously, physicians and dental support, because we know that some of the geriatric programs, and especially what Marilyn brings along, is a whole bunch of people to support this. And I think that has been critical in allowing us to do this work. Next. The other question is, the first thing I look at is, this is not about smoking cessation for longevity and for, preventing, long-term conditions, because most people are in their 70s or 80s, much later on, or, unless it's premature, they're in their 50s and 60s. But for the most part, my first issue is what is a safety risk? Because we have heard stories and anecdotes around people, because cigarettes are so combustible, landing up with burns or fires or injuries. And this is a real issue. I know the tobacco industry likes to, label it as careless smoking, but it is one of those, it is a product that is highly, problematic then in terms of causing fires and smoldering, etc. So, is there a caregiver? And in a way, if they are smoking, is it done safely? Is there somebody who supervises all the way from the storage, all the way to the lighting, to the putting the cigarette out? And when they're smoking, because we have heard of stories in the city as well, where people have been, because of smoke-free or tobacco-free policies, been sent out into the cold. They are not in a safe place to manage, and they are not aware that they are actually, the ash is falling or the embers are falling, and then they end up developing burns, and significant burns. So that assessment is a critical piece, and often something we want to know about as to where they are. So safety is first, and then next slide, please. We're also thinking about if I'm going to give medications, is it safer? It may or may not be safer, and there's particular considerations in people who have dementia and are quite cognitively, impaired, and sometimes it's that impairment may be, quite significant, and you have to be mindful. So, for example, who will be applying the patch? Because it does take some activity. When you're cognitively intact, it's nothing like, okay, you take the patch, you peel it, you apply it to your skin. Physical hygiene is okay. It sticks on, people take it off, etc. They know when it's fallen off. If people have cognitive impairments, sometimes they may not know that. So you've got to figure out who is the person going to be responsible for applying it and taking it off. Sometimes they will, for example, in the situations like this, where the person does want to put it off but forgets or tends to take it off, putting the patch on the back or in a slightly hard to reach place makes it a lot easier, because should there be any issue, then the person who's responsible for it can be called or knows that there's a problem and can pay attention to it. So that's one thing. The other one, of course, we want to know about are dentures. Clearly, as people get older, they're more likely to have dentures, and obviously gum is not a good one for this. And as you know, some people with, and so in those situations, you may use an inhaler or a short-acting or lozenge, but even that, all of those have risks. So, for example, with the inhaler, there is, people need to know how to load it. They need to know how to put it in. And here's the other risk, is that sometimes when people cannot be bothered, or if they've got cognitive impairment, they just take the little cartridge that comes out of the inhaler and try to suck back on that. And that creates a choking risk. So one really has to be careful and do a, and make sure that they don't have any impairments in swallowing, or they're not a choking hazard, etc. Because as you know, with depending on the type of dementia, and as people get older, these become risks. So gum, lozenge, inhaler, all of them can become asphyxia risks, and so you have to be careful, and that's why in choosing sort of NRTs, tend to go with the patch because it's the least likely to be a choking hazard. With respect to pharmacotherapies like bupropion, absolutely happy to use that. In older adults, you have to be a little careful, of course, if they have other coexisting mental illnesses. And of course, bupropion can cause some activation, and you want to be careful you're not activating hallucinations, etc. So, but it can be used, and it just depends. But again, one has to be a little mindful of those side effects, excluding the risk of seizures, which can occur in people who have dementia, depending on the type. With varenicline, we have no real issue. The main issue with age with that is obviously the renal function, but they have to have fairly significant renal function impairments. If they're on dialysis, you can just use the regular dose because it'll get managed with dialysis. But if they have compensated kidney disease, the recommendation, depending on what the eGFR is, you just give half the dose. We have no experience in using things like cytosine in this population, and again, cytosine requires multiple 5 times dosing per day, can be problematic. And of course, with any older person, the chances of them being on other medications, you have to be worried about drug interactions and the effects of quitting smoking on those on that. And the critical ones obviously are any antipsychotic medications that they will end up getting more sedated once they quit smoking. And of course, if they are on Coumadin, warfarin, but as long as they're getting measured, that you should be fine. You may need a dose adjustment down. But those are the kinds of things that you mainly worry about. And of course, people with diabetes and on insulin, if they are on that, as you know, the sensitivity to nicotine, sensitivity to insulin changes when people quit smoking. So you have to be making sure that they're monitored so they don't land up with hypoglycemia. And of course, often what happens when people quit smoking is this huge craving for sweets. And I'll get to that in a bit. It could be a bonus, it could be a risk, but something we can think about. So those are the medication options. And again, duration of medication in this situation is, what is the purpose? Is the purpose to manage withdrawal so that they manage to get to the point where they aren't having, the withdrawal is not driving the desire for cigarettes. And often this is what happens, especially in people with advanced cognitive impairment or dementia. They're not smoking because they want to smoke it. They're smoking because they're going into withdrawal. And so managing that withdrawal is often what is needed initially. And then they don't need anything else because the structure of the setting in which they are doesn't even, they forget that smoking is part of it. So you really need to know what the goals of what you're trying to achieve here are. Is it keeping them safe? It's a harm reduction approach. It's keeping them housed. So therefore you have to help them manage withdrawal. Or is this about them making some sort of volitional attempt to quit smoking? So it's a really pragmatic kind of approach to this. And it does take some conversation, and especially if they aren't able to consent, who the substitute decision maker is and who's making those decisions around this kind of care. Okay, so medication is in that way. And then sometimes what happens is, family members, often you need to make sure that you're talking to the family members about medication, because often they feel that smoking is the last thing that this person does, and they are often, wanting to provide the cigarettes. But of course, that conversation has to happen with them about, well, really, we are working on, it's not about trying to take away the pleasure. It's trying to make sure that they don't harm themselves and others, especially if they're in a congregate setting. And so here is the recommendation of using NRT or this, that, and it may prepare them that it might be long-term. It's just a harm reduction strategy for this person to manage. And it's not always successful, but clearly, and families have a mixed emotions about this because, as you know, many people feel, smoking is a pleasure, this is their right, etc. So it becomes a bit of a conversation to make sure that they're on board with that. And so in our medications, you may want to give them, but they just may not be available because of that, because of the family is not wanting to provide it, or that the setting does not have access to these medications. And as you know, NRT is not covered under drug benefit, bupropion and varenicline is. NRT through STOP is possible, but many people on this call know how they've been able to do workarounds to get access. Next slide.
Yeah, just so you're aware, Dr. Selby, Tarek is now joined us via.
Dr. Rajji, great. Okay, so you know what? I'll just finish up my slides and then hand it off to him. So the next slide.
Yeah.
Okay. So just very quickly, what are the environmental strategies to help reduce the harm? And this is critical, I think, because people have a lot of individual sort of things problematic, we need to take a look at what are the environmental issues that we need to do. So next slide, please. So clearly, behavioral interventions are possible inpatient and outpatient where they're sitting. Really reducing access to cigarettes is critical, but not to the point that you're keeping the person in withdrawal between that. But often it's an out of sight, out of mind, and sometimes it's amazing how well that works. And especially when people are transitioning, say, from home, going into a nursing home or something like that, the access can really be used as a way to prevent that harm and issues. Distraction can be very critical for them, and structuring of breaks from activities, because often that time of day tends to be the craving or brings the craving back, using distraction techniques. So for example, very interesting, there's one small study done a long time ago, and actually it's well known that actually short amounts of plain glucose or sugar or juice are very effective in managing acute withdrawal symptoms for the short term. The reason why we don't do that is because, of course, then people are going to land up with major carbohydrate load. But in many cases, the use of sugar candy or things that are not choking hazards but are something sweet can actually help in the short term manage withdrawal, and we've used it in one case at least where it does that. And the other thing during the pandemic, which is becoming relevant, especially in people in congregate settings, and I think we don't do this enough, is to make sure that people who are leaving, if that setting allows people to go out and smoke, is that you don't make sure that their hand sanitizer is evaporated completely before they light any cigarettes or handle any matches or lighters, etc., because you can end up, that is flammable, and there have been case reports of that happening. So that's just a little tidbit there. So the behavioral and environmental shifts, next slide please, are really critical because the person does not have the cognitive capacities to do that. So in a nutshell, that's how we do it. We at CAMH are open to these kinds of referrals and have been doing that. We've had a couple of fellows in geriatric psychiatry come through and have been worked with us, and we try to do our best to make sure that we pay attention to this group. It's not about longevity in this situation, it's really about safety. So I'm going to pass it back now to Dr. Rajji, and I'm so glad that we were able to work this out, and apologize on behalf of all of us. But let's go back to his slides, and then we'll get back to questions later. So
sounds good.
Thank you, everybody, for your understanding as we flipped this presentation.
Yes, thank you, everyone. So I'm just going to unmute Tarek. He has called in. Tarek, are you there?
Yes, hello.
Perfect.
Hi. Great.
Welcome. So I will go back. Did you want to share the slides? Or are you okay if I just share them? Tarek, are you there?
Yes, no, I cannot actually share. Like I will need someone to move the slides for me.
Okay, yeah. So just let me know when you'd like me to advance the slides, and I can do that.
Okay, great. So Hi, everyone. Great to be here. Sorry about the delay. I think we can move on. So I think the first part of this presentation was will focus more on dementia in general, some of the potentially modifiable risk factors, which one of them is the smoking, and that's kind of the link between the two sections of this presentation. So this is a slide. It's a bit old, but that kind of gives a sense of the size of the dementia problem worldwide, and you know, I mean, it's hard to imagine worldwide problems other than the pandemic now, but it is an ongoing problem. Obviously, it interacts quite a bit with the COVID pandemic, and so these are the numbers saying that, you know, every 3 seconds around the world, someone is being diagnosed with dementia. The numbers are expected to grow really exponentially, especially in low-income countries. And that's kind of to give a contrast about the cost of dementia. It's almost like the 18th largest economy compared to other economies like Google and Apple. Next, please. So this is also an infographic that has more recent information from the U.S. specifically, again, showing the magnitude of the problem and you know, more than 6 million people, and that's in 2021, living with dementia. In the U.S., our numbers in general in Canada is like one simple rule is to divide the numbers by 10. So our numbers in Canada is closer between 500 to 600. There is definitely impact of discrimination that interacts with dementia. So you can see on the top, you know, the barrier as identified by people as Black Americans or Native Americans, Asian Americans, and so on. Also shows the number about the interaction with the COVID. So during the COVID-19 pandemic, 16%. There's a 16% increase of deaths from dementia because of the pandemic. Next, please. These are some numbers from Canada environment, and again, very consistent with the total picture. So the numbers now is a bit higher, so it's closer to 500,000 people. And in terms of gender, 2/3 of people who live with dementia are women, and that's consistent across different countries, not just in Canada. And that's another way also to think of the magnitude of the dementia problems, that, you know, 9 seniors are diagnosed with dementia every hour. So the beginning of the stock and the end of the stock, there are 9 more Canadians with dementia. Next, please. So like I mentioned, overall, globally, the prevalence of dementia is going up, but it's mainly in the low and middle income countries than high income countries. And there are some studies that show that the incidence of dementia, so the number of new cases, even though the prevalence, so the number of people who, because as a population we're getting older, it continues to increase in high income countries, but the number of new diagnosis of dementia are going down over time in some high income countries. That's not the case for low and middle income countries, and that's why globally we're going to continue to see increases in numbers. Next, please. This is one study also that focuses on that increase in prevalence, but also on the gender effects. So what you can see, this is comparing 2 different studies from 2 different periods of time, from 1889 to 94 versus 2008 and 2011. And what you can see is that the numbers among men, the prevalence is going down, but that's not affecting women in terms of the difference in the increase across the different age groups. Again, we don't know the reasons for that, but there's also a gender interaction with the diagnosis of dementia. Next, please. So this is also a number, even though it's old, but it's some of the recent stats also are consistent. And I'd like to show this one to highlight the discrimination, and I believe in our practices towards the people who live with dementia and their care partners. So if you focus on the bar graphs on the right side, this is telling us that how the percentage of seniors who have a diagnosis have been diagnosed. So we're not talking about people who are not diagnosed, and we know that the number of people who are not diagnosed are also high with dementia. But people who have a diagnosis, what is the percentage of those individuals who are told about their diagnosis? And you can see the major difference between something like dementia, Alzheimer's disease, versus common cancers, cardiovascular disease, or hypertension. And we're looking at these numbers in the slide because Alzheimer's continues to be one of the top 10 conditions among like these other conditions in terms of morbidity and mortality, that we don't have any really disease modifying or even strong, effective, even symptomatic treatment for it. And so clearly there is some bias, there's some discrimination about telling people, that they have the condition even though they have been diagnosed. And I added to the slides the word demence, and I'm wondering, I don't know what the reasons for that, but is it because of this sense of nihilism that we cannot do much about it? So why tell people? And I also, I hear this argument also when we talk about screening for not just dementia, but even for mild cognitive impairment, so MCI, which is an earlier, in terms of stages of the illness, it's an earlier stage of the illness where people continue to be independent, but they show objective cognitive impairment. That there is also concern about why do we need to screen? If we can't do anything about it? I think obviously there is a debate there, and there are support for both arguments. I think and in general, if we can't do anything about identifying a condition by screening, there is less support to implement screening approaches. But what we'll go over next is that with some limitation to the evidence, we're learning more and more that there are potentially modifiable risk factors that maybe if we can intervene on them, we could reduce the risk of dementia and maybe the risk of progressing, let's say, from an MCI condition stage to stage of dementia. Now, the epidemiological, next please. So before we go into these slides, so what we're spending time in this presentation is talking about the strong epidemiological evidence, demonstrating the links between these potentially modifiable risk factors for dementia, although the intervention evidence, so the randomized control studies that try to modify these interventions are still in the early stages of development across these different conditions. But stepping back also, so we talked about in the previous slide was representing the percent of people who are diagnosed with dementia, but not informed about the diagnosis. But what about people who actually have dementia and have been missed? So the diagnosis was not screened for, was not assessed for, and that is also a major problem. It's not, we see it not only in general settings, community settings, but also in academic settings and specialty settings as well, in geriatric specialty settings, maybe that are not focused on memory clinics. So these are some clues that I'm sure all of you would know that that should give us a hint that maybe there is an underlying neurodegenerative disease, neurocognitive disorder that's contributing to forgetting appointments, repeating questions many times, starting to see medication non-adherence for someone who has been adherent on their medication for a long time, and changes in behavior that's more of a late onset, that's not that hasn't been part of the characteristic of this individual, change in hygiene and mood state and personality changes. Next, please. So so in addition to getting hints and from the clinical, from the history, are there tools that could help us in different settings to identify, as a screening tool, to identify people who may have dementia? And as a screening tool, obviously these are not diagnostic, so they are sensitive, but they are not specific, and that is okay. That's what we need from a screening tool, because we want to capture people who may have dementia and then refer them to clinics to confirm diagnosis, to rule it out or in. So in a way, it's okay, quote unquote, to be over concerned, to over identify people with concern and then eliminate that concern rather than missing them. I think that's how I see the value of the screening tool. I think most people are familiar with the MSc and the MOCA, but which they do take time, especially for someone who is cognitive impaired. But we'll next piece we'll talk about those two other briefer versions of screening tool. One is the mini-cog, and that's so that's a tool that consists of asking the person to repeat 3 words, to register 3 words, and then you can see these different versions of the mini-cog, different words, and then the next would be to ask them to do a clock, to draw a clock, and put the numbers in. Then the third step of the mini-cog is ask them to recall the words, and it's a very simple tool to score also. So if someone recalls 0 out of 3, then it's a screen positive. So that we need to be concerned that this person may have dementia. We should be referring them or having the conversation to refer for further assessment. If they score 3 out of 3 of the words, and so if they score 0 out of 3, we don't worry about the clock. We can also obviously look at it, but we don't need to worry about the clock, how they do on the clock. If they score 3 out of 3 on the recall, then also at screen negative. They score 1 or 2, then we look at the clock. If it is impaired, then it's a screen positive, and then we refer. Or if it's not impaired, screen negative. Now, of course, we can also, if part of the history, if there is ambiguity, we can always err on the side of referral. Next, please. A second tool that could be used, also simple screening tool, is the SixItem Screener. So it's a very similar concept. So we give people 3 words, then we ask them to what is the year, what is the month, and what is the day of the week, and then we ask to repeat the 3 words and the 3 objects. And if the scoring, so if they miss 2 or 3 items on total, so that's a total of 6 items between the recall and the orientation questions. So if there are 2 or 3 missed, that indicates that further assessment and diagnostic is needed. Again, so these are between the history and this simple tool of screening. Maybe we can increase the identification of people who have potentially dementia and to refer them for further assessment and treatment. Next, please. So going back to, in my mind, more of a hopeful message that why should we actually make sure that we are identifying them? I mean, not irrespective of all the implications in terms of planning and implications on lifestyle, on capacity related issues, but there may be some potential risk factors that potentially are modifiable. And so this is from the 2020 Lancet Commission report on dementia, describing across the different life stages of life, early life, midlife, or late life, the contributions, the unique contributions of different factors towards the diagnosis of dementia. So one way to read this is that as a risk factor, having low education contributes to 7% of the cases of dementia. Uniquely, that's their own unique contribution. Hearing loss contributes to 8%, TBI 3%, and you can see, so that's also when it happens. So you see those as early in midlife. Of course, the highest, here we're not talking about genetic risk factors, especially like ApoE4, and we're not talking about the strongest risk factor for dementia, which is aging. So we're talking about risk factors that theoretically could be modifiable. And you can see smoking is one of the higher ones, it's 5% in late life, depression is 4%, and so on. So in total, these risk factors account for 40% of cases of dementia, 40. So in a very optimistic scenario, if we can address those, if we can modify these risk factors, maybe could we prevent, it's a question really, can we prevent 40% of cases of dementia? Maybe this is why in high income countries, because the lifestyle, the healthcare system and the lifestyle changes that people have access to, which unfortunately people in low and middle income countries may not have as much access to, maybe that is what's driving the lowering of the incidence of dementia in high income countries. Next. So next, we're going to go over to show you the evidence for why these associations, for the evidence support these associations. So this is a proxy of the concept of cognitive reserve, which we think that's how education contributes to the lower risk of dementia. So what you can see is that all these different studies from back in the early 90s demonstrating that high level of education, occupation level, the more complex pre-morbid IQ, intensity of the leisure activities, all that contributes to higher reserve, so the ability to cope for disease process like neurodegenerative disease, and lower the risk of demonstrating of experiencing a stage of dementia. The risk is, the reduction is small, but it's still significant. Next, please. This is also an example of showing how in a longitudinal study, the others were more kind of cross-sectional epidemiological studies. So this is a cohort study in the religious order study that we learned a lot about dementia, showing more specific the impact of the level of stimulation. So as a composite of all these different activities that were identified as the participants in the religious order study were engaged in, and how the more people were engaged in these activities, the lower the risk for dementia. Next, please. So another risk factor which was also kind of surprisingly high in its contribution is hearing loss, and we really don't fully understand how hearing loss could contribute to the risk of dementia. This is a diagram showing the possible pathways and what's the evidence. So it could be that people have hearing impairment, they experience less cognitive load, so they less stimulation, because they are not hearing the conversation, they are not engaging in the social conversation, so there is less stimulation, or whatever they hear, they have to really, it becomes too burdensome on them, and that could contribute to low cognitive functioning. The hearing impairment may be associated also with other changes in the brain that contribute to the dementia as well to the hearing impairment. And the people who have hearing impairment, they tend to social isolate, and therefore it's even if they are, so not only that they are not benefiting from the stimulation during the social interactions, but also they don't actually don't get to participate in social interactions. Or there may be other factors that are, again, common etiologies that lead to hearing impairment, lead to these brain changes, or lead to cognitive decline. Next, please. Depression. So that's also something that we learning more and more since the 90s about how impactful having late life depression on the risk of dementia. So the risk is almost doubling the risk of developing dementia. This is all different studies that support this risk. These are longitudinal studies. Next, please. And what's interesting also, is that the number of depressive symptoms increases, is associated with increased risk of developing, in this case, MCI, so early stages of cognitive impairment. But what you see it here is a dose-response relationship in this prospective 6-year study. So anytime you see dose response, so by that I mean the higher the number of the symptoms, of depressive symptoms, the higher the risk of developing MCI. That suggests that there is some causality between, or again, doesn't confirm causality, but it's suggestive of that. Next, please. Now, this is a busy slide that shows how potentially could depression lead to dementia. It could be, so one pathway could be related to the stress pathway, increases steroid, the stress hormones, leading to hippocampal atrophy, brain changes, atrophy to brain regions relevant to Alzheimer's disease, and therefore decreases the reserve, the brain reserve, so that people who have some AD pathology, Alzheimer's pathology, they manifest the dementia early on. But also we know that depression is associated with cerebrovascular disease, which also can cause ischemia and therefore cause also reduction in brain reserve and therefore better, earlier manifestation of the dementia due to Alzheimer's disease. And the last pathway talks about that there may be some frontal certain abnormalities, certain regions of the brain, the frontostriatal network, which can cause both depression and reduction in brain reserve and contribute to dementia. Again, these are pathways, there's different evidence for them, but that's kind of what's been proposed as one summary of certain models that show the link with depression and dementia. Next, please. I know we're running out of time, so maybe we'll go fast at these slides. So physical inactivity is another major potential risk factor that independently contribute to 2%. And that's showing the different studies showing the association between high level of physical activity and reduction in risk of dementia. But even that reduction, you observe it in low to moderate level of physical activity. That's what you see on the bottom slide, different slides that show that. Next. What's also interesting is that the physical activity association with not only Alzheimer's dementia, which is the most common form of dementia, as you see from the top, and here you can see the level of intensity of the exercise that's associated with the reduction. So 2 times a week, 5 hours per week, 3 times per week, vigorous exercise. But it's also, so if we take out Alzheimer's dementia, so there is also some benefit to a lesser degree, but still there seems to be protective physical activity and other forms of dementia other than Alzheimer's dementia. Next, please. Diabetes, surprisingly, the contribution is smaller than other, but it's 1%, but uniquely, and again, what is the pathway? It's hypothesized that could be through the interaction, through being associated with infarcts, white matter lesions in the brain, therefore affecting cognitive dysfunction or affecting the brain tissue. So gray matter, that's another pathway as well. Next, please. TBI, traumatic brain injury, is also is associated 3% contribution. And what you see in the slide is that the association is not only with Alzheimer's disease, what you see on the upper left corner, but also with other conditions like Parkinson's disease, MCI, so that's before dementia, early stage of dementia, as well as depression and other psychiatric conditions, bipolar disorder and mixed affective disorder, which, as I mentioned earlier, like something like depression, increases on its own the risk of developing dementia. Next, please. And so there are other conditions. Obviously, alcohol, the use disorder, also is associated with dementia, poor sleep, apnea, air pollution. We're learning more of that. There's some evidence for living near major roads. Bilingualism, there's some evidence suggests that it's protective, especially if 2 languages or more are actually practiced. So not only that we know 2 languages. Next. And this was going to be the segue for Dr. Selby's lecture. This is our part of the section. So that's the smoking, which is again 5%. So again, thinking about each individual contribution. And so I want to expand maybe, but so as we know, people, let's say, who have depression, they may be at higher risk, they may be also smoking, or people who have diabetes, they may be also smoking. So when we say 5% is on its own, taking out the contribution of the depression that could be comorbid, or the diabetes, or TBI, and so on. And this is again how we potentially what we think could be contributing to the association between smoking and dementia. It could be because of the nicotine itself, so the exposure to the nicotine, and which can have some behavioral effects, sometimes positive effects in terms of cognition, but ultimately leading to negative outcomes related to hyperphosphorylation of tau, which is one of the features of Alzheimer's disease, neurotoxicity over lifespan, and dependence related changes, but also the other constituents of tobacco smoke could also contribute to brain changes, cerebrovascular disease, cardiovascular disease, and their own contribution to risk of dementia. So I think that was the last slide from my section, and I was gonna pass it to Peter, but here we are. Maybe we have to go to questions. So thank you, everyone. Again, apologies for the.
Thank you, Tarek, for your flexibility and still persisting and coming on with this technology. 2 years into the pandemic, it should be working much more fluid, like effortlessly. But so I thank you and thank you to the team at the back end trying to make this all work. So let's open it up for questions. You can put it into the chat, or if you have it in the Q&A, either one will be fine. We have a few minutes for a discussion, so hopefully this didn't depress all of us who are crossing that age 50. That we are headed. Some of us are headed towards that unfortunate diagnosis. But some of at least 40. If 40% is prevent, we can do something to prevent. Then that's great. So open it up for questions or comments from anybody in the audience. I can't see the chat. Tarek, are you able to see the chat?
I can't see the chat. I think the last chat I see is about from Marilyn. Hi, Marilyn. About the lollipops. That's the last.
Okay, let's see if I can. I'm going to try to see if I can open up the chat. Oh, there we are. Okay. So, all right. Yeah, we can. Oh, sorry, I didn't see that. Okay, no, I don't see any questions there. But Ingrid put a question. Any tools or strategies to help quit smoking for people with dementia? I mean, I think when I look at it, it's basically modification. And I think if you want to put it into if you look at the slide, it's that hierarchy of where's the setting in which you're talking to the person, what is their level of understanding and appreciation and competence, who can make the decision, what's the purpose of this, and clearly that I mean, maybe this is something Marilyn, who's on this call, and us need to talk about of coming together and creating this toolkit for people who are working with the population as to what the steps to follow once people have dementia, as to what can be done and how to work through maybe a kind of checklist is to check into these things about how competent is the person to make the decision, how safe, what is the setting in which they are, for example, what medication options are, what you need to watch for, and what's the goals of trying to intervene in someone who is continuing to smoke into late life and has cognitive impairment. So yeah, I have not come across any specific tools that maybe somebody else has or is using, and I often defer to Marilyn Campbell on these things if she's come across, because she's got her a nose to the ground for these things. But so I don't know, Marilyn, if you want to type in or unmute, please feel free to do so. And Tarek, in the dementia world, have you come across particular tools and strategies around smoking cessation?
Nothing specific I can. So there may be some Marilyn's putting some information there, but I think to your point, and and to my point earlier, I think in the chat, is that I think what is the goal? So what are we trying to achieve if we want to help people stop or use? Is it for symptoms or is it for preventing withdrawal or not? And I think that's something definitely worth considering as the discussion is happening, notwithstanding the impact of smoking on the others who are around the person who is living with dementia.
Yeah. So I think, and Jennifer puts that, yeah, this is that practice-based evidence. Everybody found this practical tip, right? In long-term care, if NRT is useful, and they're going to remove it, you put it on the shoulder where it's out of sight, out of mind, and they're not bothered by it. And Checho has asked about, can you give somebody, Champix? And again, that's the issue, is that who's the substitute decision maker? And are they going to consent to this or not? I mean, I don't think you can just, Champix is not a great sort of withdrawal management, acute management or withdrawal kind of medication. And so I think this is one of those things where we've had to have discussions with substitute decision makers around this, and it's answering those questions about, safety, what are you trying to do, and that's where it is tricky, because we've had one situation where the person had fairly advanced dementia at a young age and had HIV, had a whole host of issues, had been potentially discharged from every long-term care facility, and it was in the last one where they would at least take the person, and again was about to become homeless. So we really had to work through the substitute decision maker to make that decision as to what would be feasible and reasonable. And so we went through the list of all the medications with them. So it takes time, for sure. And I don't think there could be a guideline for it, but you just have to go, apply the evidence and pay attention to the ethics as well, in paying attention to the what is the best decision, who can make that decision. Yeah, and Jennifer, of course, I mean, clearly this has been repeatedly been told to us that when people are not, let's say a nursing home brings in a smoke-free policy, but doesn't, and says, okay, you can only go out, once every 6 hours to smoke, people are grumpy. And so even if you take, if you make sure that they don't go into withdrawal by having the patch on through the day, they are comfortable because they're not in withdrawal. And so, yeah, that is some, it's a pragmatic approach in this situation, as in the absence of good evidence and the absence of any kind of work in this space. I think it's a big gap. We really need to do that. We will certainly share the PowerPoint, and distraction and redirection is exactly important. That's why you do need the behavioral sort of interventions, and sort of it's not just about medication. It's about understanding the process and understanding how to keep the person occupied and distract them. So Tarek, any other words of wisdom or advice, or especially your last slide about the harms from potential long-term nicotine?
Yeah, I mean, I think again, it's depending on the stages. I think the earlier the stages, definitely there is more hope that smoking cessation could help reduce any ongoing harm. I think when we get into more advanced stages, again, the knowledge, that scientific knowledge is not there, but I think this is when a discussion about the risk and the benefit, that when people, as we know, we didn't talk much about that, but the dementia is not only about memory, it's about also all the behavioral symptom, neuropsychiatric symptom, responsive behavior, that people experience who are living with dementia, and how much is this being contributed to withdrawal from certain conditions or nicotine or others. I think that all that needs to be taken into consideration to provide really holistic treatment plan. But the earlier, definitely the recommendation is to try to stop.
Okay, I think at time, but I think this is a very interesting topic, and we will certainly make the slides available. And on behalf of all of us, thank you so much, Dr. Rajji, for taking the time to be with us. And thank you to everybody for joining today. Stay well, stay safe, and hopefully the next time we're talking, Omicron isn't as much of an issue, and we can be everybody's feeling better on the other side of this. So take care, everyone. Take care of yourselves, and thank you so much for joining us today. And thank you, everyone.
Yeah,
Thanks.
thank you so much, Dr. Selby and Dr. Rajji. If anyone needs to head out now, feel free. I'm just going to go through some other housekeeping slides just as we finish up. So if you have any other questions, content-related questions for Dr. Rajji or Dr. Selby, feel free to reach out to them via email. And so just before we head out, I want to remind everyone that this webinar has been recorded, and we will be distributing a link to it as well as a copy of the slides to you all this afternoon. Please feel free to share this with your colleagues. Along with this, I'll also be sending a link to the evaluation and post-learning assessment that must be completed by next Wednesday in order to receive your letter of completion. We also just want to take the time to let you know about our next upcoming webinar in February. That will be a panel discussion on smoking cessation and virtual care. The exact date and time and registration is to come, so keep an eye on our website for that. And if you missed a portion of today's webinar or would like to view it again or see a previous Teach webinar, an archive list can be found on our website here. For now, thank you all so much for listening and for your patience with all our tech difficulties. We hope you all have an amazing rest of your day. Thank you and bye.